Well, thank you so much for staying glued to your screen. And if you made it to this stage, don't worry, we have something in store for you.
Exactly. Well, today we're going to be, or right now, we're going to be moving our focus now to a condition that affects some children from birth. Many parents are often unprepared for it. It's called clubfoot. Yes, we're going to look at what it is, what causes it, how can it be treated, and our guest who will be joining us via Zoom this morning from Birnin Kebbi. His name is Dr. Anipol Olalekon. He is a consultant orthopedic surgeon at the Federal Teaching Hospital, Birnin Kebbi. Thank you so much for joining us on the program. Good morning. Welcome back. We're still on with Dr. Anipol Olalekon, the consultant orthopedic surgeon, Federal Teaching Hospital, Birnin Kebbi, talking on clubfoot syndrome. And just before that break, Dr. Olalekon, I asked, many Nigerians don't really understand what clubfoot is all about. They may have heard of it but don't understand it. So for clarity, what exactly is clubfoot syndrome, and how does it present in children?
Thank you. Clubfoot is another word called congenital talipes equinovarus. Congenital means the child is born with it. Talipes means it affects the ankle and the foot of the child. Equinovarus means that the foot and the ankle, they are turned inward and downward. So pictorially, it looks like a golf stick. When it is left untreated, the baby start walking on the side of the foot. And it can even be worse that they start walking on the upper part of the foot. The foot turn inward like that, and the children start walking on the upper side of the foot, the upper part of the foot that's supposed to be on top. This can be very uncomfortable. In fact, it can also lead to soring, pains, of course, not comfortable, apart from the aesthetic part of the foot. So it's it's one of the commonest orthopedic presentation or condition in children. In fact, it's like the commonest congenital foot anomaly in children. It's occur in out of 1,000 deaths, about 1 to 2 child are born with clubfoot. This one that is the commonest part. There are different types of clubfoot. You have the idiopathic, you have the syndromic. The syndromic is even the minor part of it in terms of epidemiology. The most prevalent one are the idiopathic, which occur as a cause with no known cause. When you say idiopathic, it means that there is no known cause. So most of them are idiopathic, so there's no particular cause. Though there are theories that have suggested, but all of these one, they are just theory or hypothesis. They have not really been established. So it's quite common, 1 to 2 in 1,000 live births. It tends to affect male more than female with a ratio of 2 to 1. And then it's said to be found that even among like 80% of them, they have been found to occur in a developing state, developing country. Up to 200,000 children are born with clubfoot annually from a record from statistics. So it's quite common, and it's a treatable condition. That is why it is important for the public to know about it, so that when they come early, the patient can be given a normal foot.
Okay, thank you so much, Dr. Olalekan. As a consultant orthopedic surgeon, what would you say is the treatment procedure? Can you please walk us through?
Thank you. The treatment procedure for clubfoot has actually gone through historical lane. However, the universally accepted treatment method now is the one we call Ponseti treatment that came from Iowa all the way from America, and it has come all the way down here, common in Nigeria. Most orthopedic surgeons are conversant with this treatment, and all it involves is manipulation and casting, using the hands to reverse the abnormality. So this had to be done serially. So patients are brought to the clinic as early as they are born. The child is born within that 1 week, within the week of birth, patient should present to the hospital and treatment starts. So we go through a series of manipulation and manipulation, manual manipulation. After you have manipulated it, you cast it. The key to the treatment was actually discovered by this man we call Ignacio Ponsetti, all the way from America, like I said. And he found out that the structure in the foot of these patients, unlike the normal children, that the structure in their foots, they are as against those normal foods, the structure in the foot of the clubfoot patient, they are quite elastic, more than necessary. And so, and you know, elasticity, what characterizes it when it is drawn, it goes back. So those foots are in the inner and the posterior part of the foots, and they draw those foots inwardly and downward. And so what you do is that we keep on stretching them back to normal, not at once. It has to be a gradual process. So on weekly basis, patient comes, you manipulate and keep it in that form with POP. And then that can continue for like 4 to 6 periods, depending on the severity of the deformity. And after that time, patient goes to the second phase of treatment that we call tenotomy. The inward part is corrected by being turned outward. The downward part of the foot is corrected by a small procedure in which a blade is used to nick off a taut and strong rigid structure on the posterior part of that foot, which will now permit the foot to become finally normal. And this will grow out and join back within three weeks. We call that percutaneous stenotomy. And after that, patient is placed on this POP for a length of about 3 weeks for the healing of that structure to occur, which will occur perfectly. After 3 weeks, patient is now placed on what we call foot abduction brace. This is a special shoe worn by the children, which is connected by this by a bar, and this will keep the foot in the corrected position. If you don't do this, it will go back to that abnormality we recall, and that's the commonest complication. There is high tendency for the deformity. There's high tendency for the deformity to recur. So to prevent this recurrence, the use of the clubfoot shoe that we call foot abduction brace is very, very paramount. Therefore, we can even say that the treatment of the clubfoot, two phases, the corrective phase and the maintenance phase. The corrective phase forms about the 25 to 30, 40 percentage of ability to prevent recurrence. But the maintenance phase, which is the use of the foot abduction brace, constitute about 70 to 80% in aspect of prevention of the recurrence. So that foot abduction brace is very, very, very key. And it is even at that point that we really need education on the part of the parents, because once they see the foot has been corrected, they can go to sleep, and then the pathology underneath the deformity begin to recur again, and the foot returns back. So that is the treatment of the clubfoot that is prevalent now universally.
Nigeria, particularly in the rural areas and even in the urban areas as well, most people often attribute birth conditions to some superstitious beliefs. Some would say it's a spiritual cause, or some would say, it's a maternal mistake from the mother or something. So, in your experience, what are the common misconceptions that you've encountered among Nigerian families when it comes to this clubfoot syndrome? Some people also think that it's hereditary as well. So, what are those misconceptions that you've encountered over time?
Yeah, thank you. This is one of the experience that we've been having in the course of treating this patient. Some, like you said, cultural belief, traditional belief. Some we need to, yes, let's talk about the problem before we talk about the way to solve the problem. A number of them believe that some of them believe that there is a cause. Maybe the mother possibly have taken certain things, or there are uh, maybe spiritual aspects to it. Well, in my course of treatment, the spiritual perspective to the cause have not really been presented. But I think where we have challenge, it's when it comes to the treatment. especially the second phase of treatment where we want to do the tenotomy, the cutting of the structure that is taut and it needs to be relieved. Some of them just feel that maybe they don't want anything like surgery to be performed, but it's not really surgery in its and the name surgery, just a procedure. I think there's few challenges that we have had, but be as it may, in our environment, there are likely to be cultural bias and misunderstanding. And so what we tend to let them know when we come up like this, to let them know that it is not the fault of the mother. Like I told you, there are the greatest percentage of them are called idiopathic clubfoots. And idiopathic means cause not known. They just happen sporadically. They just occur. So there are theory, but there is no established theory. They can for the idiopathic. That's why medically it is called idiopathic. So it's not the fault of the mother, it's not the fault of the father. However, there are being linked to family history. It's been found that maybe in the family it may be more common in the family where it is found than family that it does not exist. There are also been some relationship between twin gestation. If it is found in one twin, the chances of having in the second twins is also higher than in normal children. So, however, there is no known cause. It's not really established. There is other small subset of clubfoot that we call syndromic clubfoot. This syndromic clubfoot is the one that occurs with other congenital anomaly the child is having. The child may have congenital anomaly, maybe affecting the bowel, the intestine, affecting the spinal cord, or spinal vertebrae, or other part of the body, and the clot will just be part of them. These are syndromic, different hypertrophosis, multiplex congenital, spinal bifida, and so on like that. But these are smaller subsets to they compare to the idiopathic clubfoot. However, for this syndromic clubfoot, it has also been noted that the exposure of the mother, which is generally for all congenital anomaly, exposure of the mother to toxic substances like alcohol, smoking, tobacco, and some other chemicals or toxic exposures can actually cause some of congenital anomaly, not for clubfoot alone, generally congenital anomaly, of which clubfoot can just be one. Like I said, the highest number of percentage of clubfoot are idiopathic clubfoot, no known cause. So no one to blame, no cultural background or cultural cause, no spiritual cause. They are not linked to any of these factors.
Okay, thank you, doctor. Now, I want to know what are the signs of the reoccurrence of clubfoot? Can you hear
Thank
me?
you very much. Like I told, yes, I can hear you. So the signs of clubfoot
The reoccurrence.
recurrence, the recurrence, yes, we call it recurrence. The recurrence of clubfoot is the reverting back to what the deformity was before we start the treatment. So deformity, like I said, it's curvature of the foot and the ankle, inward and downward. So the treatment will take care of that by reversing that position. So the foot will go outward and then it comes upward. Of course, looks like a normal foot. Should be the sign of full correction is the foot has to be soft. The foot has to be what we call plantigrade, meaning that achieve the normal position. It has to be functioning. Now, but by the time these things are the deformity is now going back from outward is now turning inward, from moving from up is now turning downward. The patient has to now be walking maybe on the side of the foot or toe walking, and then any of these that we see in the patient show that there is a sign of relapse or recurrence.
There is a medical procedure which is called Posenti method. So does it still work when a child is presented at an older age, let's say 5 to 10? Does it still work, or does it will it require any medical or surgical procedure?
Yeah, thank you very much. When the patient comes, as much as we emphasize that we want to get this patient early, because the earlier the patient presents, the easier the treatment is. Like I said, Ponseti method is the universally accepted method, irrespective of what age the child is presenting. We will still start with Ponseti method. If the child has come at early stage, is likely going to get away with the treatment on Ponseti maneuver alone. But if the child comes as late as 5 years, 10 years, we will still start with Ponseti method. At that age, there are likely to be some other changes that will demand surgical procedure. The bone that could have been bone changes, which Ponseti alone may not be able to take care of. And so after you have started with Ponseti method, because Ponseti method, we reduce the extent of surgery that you're going to perform on the long run. Surgery in the past was one of the procedures that was used to treat Clubfoot. But it was found that it was fraught with complications like stiff foot, painful foot at the end of the day, and of course, recurrence. And so that is why we have to, the study have to revert back to this Ponseti method, which is now giving a better yield, a better result. However, if the patient comes, like I said, we call it a neglected Clubfoot. We still, a lot of neglected Clubfoot have been treated with Ponseti alone. However, some of them that have now associated with bone changes, severe bone changes, you will start with Ponseti, reduce the extent of surgery. Like I said, surgery is fraught with complications. So you reduce the extent of surgery so that those complications can also be minimized from surgery. And at the end of the day, you now use surgical procedure to correct the other deformities that are left. There are different boning surgical position that can be done. There are soft tissue. When you say soft tissue procedure, soft tissue include the tendon, the ligament, the fascia. There are all of these, because when the patient comes with neglected Clubfoot, the soft tissues are contracted, meaning they are taut. They are already contracted and they are taut, difficult to stretch them. So for this one, you have to go and do surgical release. You release those soft tissue. And then the bony deformities are there that you cannot use the hands to correct. Those procedures may need that you may need to cut part of the bone to reset the foot in an alignment that looks normal. And then, so these are the procedures, soft tissue procedure, different type of bony procedure that we call osteotomies. And then at the end of the day, patients will come out with a fair good outcome. But the earlier the patient presents, the better for both the surgeon, both the therapist, and the patients.
We've seen some untreated cases that are still visible in some communities. Now, I'd like to know, what exactly would you say are the consequences if a child grows up with untreated Clubfoot? I mean, grows up to even the point of being an adult. Does it get to a point where nothing can be done anymore and the foot has to be amputated? Does that occur?
Thank you very much for that question. There are consequences of having untreated Clubfoot. For the child, physical consequence, emotional consequence as regard even their careers. Talking about physical consequence, patient walking with a dozen, the back of the foot, the top part of the foot, that will not be comfortable. That will not, it can lead to, like I said, ulceration of the skin, and all of this can lead to untold complication, infection, wound getting infected, and of course pain. Patient won't be able to have a good quality of life. Apart from that, the site is not, it doesn't look aesthetically fine. It's not, and this can be a kind of a psychological problem for the patient. It can be a form of among the colleagues, of course, patient will not feel will not feel fine psychologically. So all of this, by the time patient is also getting up, getting career, application for job, it can also be a way of sideline the patients. So all of this psychologically will affect the patients. The job that the patient will have loved to do because of that, especially if it has to be a physical job. For instance, now sports, the patient will be handicapped to some extent. So the inherent talent in the patient can actually be limited. So these are the consequences of the Clubfoot. However, at any age that the patient presents, treatment can still be offered to the patient. So like I said, there is no condition of Clubfoot for which amputation is indicated. No. If manual manipulation by ponseti method wouldn't work, not that it will not work, we will start, like we said, we will start with it. It's just that the achievement may be limited. So wherever we are able to get to with ponseti method, then we proceed and go for surgical procedure. So whichever age, even up to the adulthood, will still be able to treat the ponseti. At the adult age, there are other things that we can do apart from the osteotomy that I talked about. When it's so bad, we can do triple arthrodesis, in which all the three joints around the midfoot, we can work on them and use it, do those osteotomy dimension, and then try to put the foot together to be in alignment. And then there's this another procedure that we call Elizarov techniques, in which we use external fixators like a ring structure like this, and then we also apply it on the foot. With this, we apply this and teach the patient on how to do some adjustments of the knot on that setup. As the patient adjusts the knot, the foot gets corrected from in phases and get corrected until the whole deformities are corrected. The deformities have different components. So we put this ring to correct each component from phase, from time, from at intervals until the whole deformity is corrected. On the long run, we will get the foot to be functioning and to look better. It may not look exactly like the natural leg, the other way, the normal leg, but it will still give the patient an appearance that is patient will appreciate. We have a better satisfaction and a functioning foot.
For some conditions to be confused with clubfoot, like how do doctors confirm that it is actually clubfoot that child has and not another deformity altogether?
Thank you very much. The diagnosis of clubfoot is easy. It's actually clinical. Even right from the womb, clubfoot can be detected with an ultrasound. After birth, the child is born. Clubfoot is easy. There are other deformity that looks like clubfoot, but there are 3 components or 4 components that clubfoot comes with. Each of the foot is divided into 3: the forefoot, midfoot, and then the hindfoot, then the ankle. All of these 4 parts of the ankle and the foot, they are affected in clubfoot. So for the forefoot, that's when the foot turns inward. At the midfoot, it turns somehow inwards too. And then there's what we call high arch foot. It occurs in that midfoot. Then the hindfoot, it rotates inward. And in the ankle, the foot turns downward. So all these 4 components of the clubfoot, when you find it in the foot of the child, that is clubfoot. And of course, there might be other parts of the other structural changes too. The leg can be small, the foot can be smaller than the normal foot. The calf muscle can be smaller in girth compared to the other foot. But basically, those are the 4 components. Other congenital anomaly that could look like Clubfoot, but they are not Clubfoots. There's some of the one that's like opposite of Clubfoot. That one we call it Kakinovargus deformity. That one is turned outward and then turning upward. That's like opposite of Clubfoot. There's one that is also having a part of component of Clubfoot. That one is called metatarsal adductors, in which only the forefoot is turned inward. It doesn't have other three components. So there are other kind of Clubfoot. There's other one that we call vertical talus and all of some other Clubfoot, but these are the commoner ones that usually come as a differential of Clubfoot.
Clubfoot is quite rampant in the northern part of Nigeria. So we would like you to clarify on that. How true is that?
Yeah, Clubfoot is we have seen quite a number of Clubfoots in the northern part of the country. There is it's just an epidemiological study. It's not only in the northern parts. I've stayed in northern part of Nigeria for like some years now. Before coming here, I was in the southwestern part of Nigeria. It was quite common in the southwestern part of Nigeria where I was too. So, and I think we are seeing Clubfoot not almost every part of the country. Now, there is a body that is helping in the management of Clubfoot, because one of the challenge of the Clubfoots is finance, the ability of the relative, the parents to afford the treatment of Clubfoots is one of the challenges that we are having in the management of Clubfoot. Like I said earlier on, Clubfoot is generally common. 80% of Clubfoot patients are found in the developing nation. The reason has not been established, but that's the findings. It's just epidemiological findings.
It's a common question that parents ask when it comes to this Clubfoot issue. Now, are there any lifestyle or prenatal factors that mothers can pay attention to that may, help reduce the risk of Clubfoot?
Yeah, the Clubfoot we are talking, like I said, most of the Clubfoot are idiopathic. There is no known cause. So it's not linked to any lifestyle. It's not linked to what the mother has eaten or what the mother is not eating, what the mother is doing or what the mother is not doing. It's not linked to any habits. It just occurs sporadically. So that's why we call it idiopathic. But like I told you, the smaller percentage of Clubfoot that we call syndromic. So we have the majority of them are idiopathic, no known cause. But the small part of them are syndromic. Those ones occur with other congenital anomaly in the body. Those ones will have some associated factors like exposure to radiation, toxic substances like alcohol, tobacco, smoking, and so on like that, chemical agents. Those ones have been indicated in those patients that have that have syndromic Clubfoot. But majority of the Clubfoot patients are idiopathic. And so being idiopathic, there is no known cause.
Doctor, that was a very, very wonderful one. Thank you for joining us.
So like I said, that the treatment of Clubfoot, the financial aspect of it has been a challenge. And most of our number of our patients, there's a number of them that drop out. Some of them may not be able to afford the treatments. But I've been found there are some NGOs now in the country, thanks to NGO like Miracle Fit, is abroad based, and through some other 5 NGOs in Nigeria, they have been able to alleviate this problem that we have with our patients procuring, affording treatment. They've been able to come in to provide almost all needed materials to treat the patient, because on a weekly basis, the patient has to be paying for treatment, buying POP, softband, and other materials. And this can be quite distressing financially for some of these parents. Some of them come from distance. So, but through these bodies, we have been able to help, they have been able to help our patient provide all the means of treatment, material for treatment, free of charge. So they even subsidize their transport for those who cannot afford it. So this has made us to have this patient early. In fact, there's also public enlightenment program that are given to the public, and capacity building to train people to be able to reach out to these patients close to their home. And with this, we have been able to have more of patients presenting early for treatment. So that is a good achievement on the part of Miracle Fit.
Okay, thank you so much, Dr. Anipol Olalekan. Thank you so much. Thank you for joining us. That was very, very enlightening.
Thank you for joining us.
You're welcome. Thank you very much.
All right, with that, we've wrapped up our conversation on Clubfoot. I hope you learned a lot, because we did, didn't you, Lillian?
Yes, I did. I did.
All right, now we'll be, showing you an interview on the extrajudicial killings in the Southeast. And we had that conversation with Mazi Emeka Umar Balasi, a criminologist and researcher, Inter Society. Do enjoy and have a good day.